Medicine faces challenges that doctors may not always address publicly. We sometimes order tests based on established protocols, even when the immediate patient outcome isn't definitively improved, often when other clear paths are uncertain. I've spent over 20 years as a neurosurgeon. I've ordered thousands of brain scans and neurological tests. I've seen those tests save lives. I've also seen them send patients down pathways of additional testing, procedures, and interventions that could have an unexpected impact on their well-being. After 60, the stakes of this calculation change dramatically. The aging brain has less reserve. The aging body tolerates interventions with more difficulty. An incidental finding on a scan that would be managed conservatively in a 40-year-old can trigger a series of decisions in a 70-year-old that diverge from the initial expectation. Today I want to have a transparent discussion about practices that specialists may not always have the opportunity to cover. 5 brain and neurological tests that patients over 60 are regularly referred for, and where the evidence for benefit is weaker, or the risk of the cascade it triggers is greater than most patients are ever told. This is not a case against testing. Testing saves lives. Imaging saves lives. My purpose is not to discredit effective medical practices. I have considerable interest in helping you understand when to ask harder questions. Test 1. Incidental brain MRI findings requiring surveillance. This is not a test itself. It's a consequence of a test. And it is one of the most significant quality-of-life issues I see in my practice. A patient over 60 gets an MRI ordered for a headache, a fall, a routine check. The radiologist finds something that was never expected. A small meningioma, a minor vascular malformation, a pineal cyst, some dilated spaces around blood vessels called enlarged perivascular spaces. Something that has likely been there for decades, producing 0 symptoms. Suddenly, that person who felt perfectly well 2 weeks ago is being referred to a neurosurgeon, possibly to me, for evaluation of something they now know exists inside their skull. The evidence on the natural history of most incidental brain findings is actually quite reassuring. The large majority of incidentally found meningiomas in patients over 65 never grow significantly. Many never change over 5 or 10 years of observation. Pineal cysts are almost universally benign and stable. Enlarged perivascular spaces are typically age-related and clinically insignificant. The follow-up appointments, and sometimes surgeries, that result from findings that may have been better left unreported or more clearly contextualized can create a sense of unease and lead to further evaluations. The question to ask when told about an incidental brain finding: what is the actual growth rate of this specific finding? And what are the published odds it will cause symptoms in my lifetime with no intervention? A good neurosurgeon will give you a complete, data-grounded answer. If the answer involves a lot of hedging and very little specific data, that itself is important information. Test 2. Carotid artery ultrasound screening in asymptomatic patients. Carotid ultrasound is a non-invasive test. It carries no direct risk. So why am I including it? Because what it finds in asymptomatic patients frequently leads to interventions whose benefit in that population is not clearly established, and whose risks, particularly in older adults, are real. Asymptomatic carotid stenosis, narrowing of the carotid arteries without any history of stroke or TIA, is found in significant percentages of older adults. The debate in vascular medicine around what to do about it when found has been intense for years. For many patients with asymptomatic carotid stenosis, the best medical care, including blood pressure control, antiplatelet therapy and statins, can be as effective in preventing stroke as surgery, according to current evidence. In a 75-year-old with multiple comorbidities, the surgical risk of carotid endarterectomy or stenting can approach or even exceed the annual risk of stroke from the stenosis itself. The incidental finding of carotid stenosis in an asymptomatic older adult frequently triggers a referral process that ends at a vascular surgeon's office, where the recommendation is often surgery. Not because surgery is clearly better, because that is what vascular surgeons are trained and equipped to offer. The question to bring to any specialist following an asymptomatic carotid ultrasound finding: what is my absolute annual stroke risk with optimized medical management specifically given my health profile? And how does the surgical risk compare to that number? Test 3. Routine EEG for nonspecific symptoms. Electroencephalography, the EEG, measures electrical activity in the brain. It is the right test for specific questions: confirmed or suspected seizure disorders, certain types of encephalopathy, sleep disorders like narcolepsy. It is a poor test for non-specific symptoms that older adults frequently present with: cognitive slowing, fatigue, occasional memory lapses, mood changes. After 60, EEGs often show age-related changes in background rhythms that are not clinically significant but that can be, and sometimes are, interpreted as pathological. The result? Additional testing, sometimes anticonvulsant medication trials in patients who never had a seizure disorder, and the anxiety that comes from being told your brain's electrical activity shows something. The EEG is a test designed to answer specific clinical questions. When it is ordered to look for anything wrong in a patient with vague cognitive complaints, it frequently generates findings that are not helpful and sometimes harmful. The question before agreeing to an EEG for general cognitive concerns: what specific clinical question is this test designed to answer, and how will the result change what we do next? Test 4. Repeated neuropsychological testing without clinical indication. Neuropsychological testing, comprehensive cognitive assessment, is one of the most valuable tools available for understanding brain function in aging, when used appropriately. The issue arises when testing is repeated frequently, every year, sometimes every 6 months, in patients whose results are stable, without a specific clinical reason to expect change, or when patients pay for concierge-style cognitive monitoring services that perform detailed testing far more frequently than the evidence supports. The problem with frequent, repeated neuropsychological testing is specific. Anxiety and test performance interact directly. Patients who are highly anxious about their cognitive function consistently perform worse on cognitive tests than their actual baseline. Repeated testing drives repeated anxiety. Repeated anxiety drives artificially suppressed scores. Artificially suppressed scores drive further evaluation. I've seen patients who function extremely well in their daily lives, who read, write, manage complex finances, maintain rich social lives, perform below clinical cutoffs on neuropsychological testing because they arrive at the testing session with months of accumulated anxiety about their cognitive health. The recommendation: neuropsychological testing when there is a specific clinical concern, a meaningful change in functional capacity, or a meaningful change in someone who knows them well. Not as routine annual surveillance in the absence of those concerns. Test 5. Whole brain MRI for general cognitive screening. MRI is an extraordinary technology. I use it constantly. I rely on it for every surgical patient I treat. The resolution and specificity of modern brain MRI has transformed neurosurgery. Brain MRI as a general screening tool for cognitive checkup in neurologically asymptomatic patients over 60 is a different question. The sensitivity of modern brain MRI is very high, meaning it finds a great deal. Much of what it finds in the aging brain are changes that are expected, age-appropriate, and clinically insignificant. Mild white matter hyperintensities, small lacunar infarcts that were clinically silent, age-related brain volume reduction, incidental small vessel changes. The problem is that these findings often lack appropriate context in the radiology report. When a radiology report mentions mild white matter hyperintensities, small vessel ischemic changes, without explaining that these are extremely common and often clinically insignificant in adults over 65, found in 60 to 70% of that population, it can cause patients to spiral into unnecessary anxiety and further tests. What MRI is absolutely appropriate for? Patients with a significant, meaningful change in cognitive or neurological function. Focal neurological symptoms. Moderate to severe cognitive changes. Not a general wellness check on a neurologically asymptomatic adult. The question before agreeing to a screening MRI: what specific change or symptom is this scan designed to investigate? I want to be clear about something important before I close. None of what I've said today means avoid all brain testing. Testing finds things that need to be found. Imaging identifies conditions where early intervention genuinely saves neurological function and saves lives. What I'm describing is the difference between testing that is driven by a specific clinical question with a clear pathway to a decision that will improve your outcome, and testing that is ordered because something needs to be ordered, or because it is available, or because the patient is worried and a test feels like action. After 60, with less physiological reserve and more sensitivity to the cascade that an incidental finding can trigger, the second type of testing carries a cost that younger patients don't face to the same degree. The principle I want to leave you with: before any neurological test, ask the question that good medicine requires. What specific clinical question does this test answer? And how does the result, either positive or negative, change what happens next? If the answer to how does the result change what happens next is it probably doesn't change much, that is the most important information you could receive. Tell me in the comments, have you ever been through a cascade of testing following an incidental finding? What was that experience like? I read every comment. Take care of your brain. Ask the hard questions. Be informed before every test. All information in this video serves as general medical guidance, informed by current neuroscience research and clinical expertise. It is not a substitute for individual medical advice. Please consult your physician for any decisions regarding tests or treatments.